Welcome everyone to Dave's part 2 of his discussion about the novel coronavirus, that SARS2, that we all know as the disease with COVID-19. This particular talk is part 2 because part 1 was one that he gave in December that was talking about the virus itself and things about the virus. Today, he's going to be focusing a little bit more attention on the social impacts of the virus and what it's done, so that how it really has upended the modern world. And this is going to be a fairly long presentation again, but it has been thoroughly researched. And so I hope that everyone will enjoy it and it can answer some of the questions that you might have. So over to you, Dave.
Thanks, Jean, and welcome everybody. Welcome back to everybody who saw this in part 1. I'm going to have to move very quickly. In part 1, I decided I was going to try to park some material at the end. I've really not done much of that. In this presentation, I also don't have any additional reading, for which you may be grateful. There were 80 pages of it the first time. You'll note on the first page here that there's a URL down in the left-hand corner. That's going to get replaced in the next day or two, just before we put it up on the web. If you look in the bottom right corner, you'll see a little red marker. That is the citation number. I've got them scattered through the presentation, and what they do is show you where I got facts or data or additional reading that you might want to do. They're not supposed to be comprehensive citations the way you might expect in a scientific paper or anything. They're just to give you some additional reading if you're interested in finding out where things originated. Come on, you. Let me get this to work. Okay. So this is just my layperson's view. There are lots of other people who have quite different views than this. One of them in particular came to my attention. His name is Dr. CACOR. He and I really disagree, but what he wrote that I was reading was written a number of months ago when there were only about 300,000 dead. We actually have a little bit over 2,170,000 dead as of this morning. And so his opinions may well change. The material was divided, as I said, into 2 parts. Today, we're looking at some reminders, but also the societal background, what we did as a public health response, the medical response, the economic effects, the social effects. There are a couple of annexes because there are some areas that I really don't have time to get into, but you might be interested in looking at them on your own later date. Sorry, I have to get rid of something on my screen here. Okay. I decided to move some material that would otherwise have gone at the end of the talk right up to the front in case you have to leave early. We're very likely to get 3 waves. We have indeed already passed 100 million cases and 2 million deaths. I'm just making a wild ass guess. We're going to have 3 million deaths by the end of March. It really depends on whether some of the newly emerging variants about which I'm going to talk really get going in the population or not. And while elders have been hit very hard, there are a lot of young people who are dying and who may be left, if they have lived, with long-term health effects, so that could be quite problematic. And I would venture that we have a huge challenge facing us. What you might want to do as an individual yourself, I would suggest distancing and masking remain excellent ideas. You should remain home. If anybody in your home is infected, you need to isolate. You should be spending limited time with others, talking over the phone, over Zoom, over Skype, whatever it might be, probably the best idea. You might want to get yourself a pulse oximeter. If you don't get one, they're available online, but probably also in your neighborhood pharmacy. If you don't get one, you need to learn to recognize cyanosis and shortness of breath. And if you get those, you need to be going to the hospital because you've got low blood oxygen. You'll see why that's important as I go through the talk. You might want to be talking to your physician early about what kind of care you're going to get. Some of this may involve having to go to the hospital as an outpatient, even if you're not sick enough to be admitted. You probably do need sleep now more than you ever did before. You may want to be taking some supplements. Some of them are listed here. We're going to see that again as we go through the presentation. You may want to be aware that if you think you might have been exposed, if you raise your body temperature to about 39 degrees C and simulate a low-grade fever, that actually will help you to kick in your immune response and may well improve the course of your infection. You may want to be ventilating or purifying the air in your house, car, wherever else you may be, and definitely remain isolated if you do get ill. So this is some stuff from Dr. Fauci. Everybody probably familiar with this fellow. Got a new role now under the new president in the United States. He's got a baker's dozen of ideas that are important about this. So we do know that it was actually out in November, not December. It may have been in other places around the world, not just China at that point, as a matter of fact. It can look quite different from person to person. Some of that has to do with the genetics of the individuals who get affected. You can be infectious even if you don't have symptoms. Spread through the air. Many people think masks work, but they probably are really only working in conjunction with other measures. Super spreaders are driving infections. There was an article today about a super spreader event where some 80 infections were caused by one person. Not everybody who goes to the hospital needs a ventilator. In fact, early on, we were ventilating a lot of people, and we're doing far fewer ventilations now, and we're having better outcomes. If you've got pre-existing conditions of various types, you may get worse illness. This includes pregnancy. Kids can get sick. Some of them can die. They can definitely pass on the disease. We don't really know how long immunity is going to last. A lot of people think there are reasons to be hopeful. If you know me, you realize one of my mantras in life is hope's just not a very good strategy. It's going to continue to mutate. He was talking about the United States experience with Blacks, Latins, and Native Americans, but we've also found that in Canada and the UK, and I'm sure other places. It's worse in people with darker skins, but we don't know whether that's because of anything that has to do with their vitamin D levels or their genetics, or perhaps simply their socioeconomic conditions. So all the caveats that were in place for part one remain. The science is exploding, the infodemic is raging, the data are unreliable. We have a new caveat now, which is because we're introducing into this discussion human behavior. We're not just talking about the virus, which in many senses is quite predictable. So you never know what was going to happen. In the United States, they decided to continue with the NFL, and in Canada, our CFL, Canadian Football League, got canceled. So who can tell what's going to happen? The virus emerged and quickly got characterized. We know exactly how it looks. We've got micrographs of it. We know how it works. It was quickly spread by air transport. It's gone virtually everywhere. No continent, no country, no island has escaped. This has been going through our populations in repeated waves. This is exactly the experience that we had with H1N1 in 1918-19, and in fact, wave 4 of that happened in 1920. This is the example of the kind of graph that can be produced to show what the experiences were like in particular jurisdictions. This was Canada. There are many more in the annex at the end that you can examine, and you can get these things off worldometers among other sites. The severity of the illness has really varied a lot. We've had some epicenters. Typically, these have been places where people are working close together. Long-term care homes have, on the other hand, also been places where there's been a lot of illness and death, and they're really in the news in Ontario right now because we've got the new UK variant, which is very transmissible, apparently circulating in at least one home in Ontario at the moment. Lots of different things contributing to how ill people get and whether they die or not. The American experience, as just one example, yes, a lot of elders hit, but also a lot of young adults. And in fact, probably the deadliest month in modern America was suffered in July. And I haven't got updated numbers, but I wouldn't be surprised if this fall and winter we will surpass that in the United States. The societal background is basically we have a very complex society that we've got nearly 8 billion people now. This is approximately 7% of all the people who have lived in the past 50 kilo years. That's thousands of years, of course. So huge numbers of people were present to get infected. We still have a growing population. Our industrial age is highly reliant on machines and science. Some people call it the Anthropocene because of the extent to which we are changing the earth. We have very complex politics. There are 219 or so affected countries and jurisdictions. There are only 195 recognized countries. We produce about $88 trillion worth of economic activity each year, 11,000 or so dollars per person globally. Most of us live close together in cities. We consume about a quarter of all the plant production on the planet. And we're producing about 33 gigatons of greenhouse gas every year. And if you take into consideration land use changes, it's closer to 43 gigatons, which is a tremendous amount. We have widely varying systems in all our various countries, but not just between countries, also now within countries as a result of the immense ability of humanity at the moment to move from place to place. So we really have a choice. Bonus points, if anybody knows the source of this idea, it's not a quote. At the moment, we seem actually not to be doing a particularly good job of self-regulation. So the public health response, early on, the public health response really had a goal of preventing people from getting hospitalized, and once in hospital in the medical care system, if you will, the goal was that we not have deaths. We've had an emerging societal goal, which is to try maintaining equitably sufficient economic activity to support those other two goals. We were really not particularly well prepared for pandemics early in the millennium. We had a couple of scares already, and a lot of countries, including Canada, reorganized how they would plan to deal with this kind of event. We even created a new public health agency. However, a lot of places started cost cutting and shelving and allowing, for example, equipment not to be replaced. As a result, in what I call the cult of efficiency, if resources aren't in use, then they're seen as being wasted, which I don't think they are. And we just proved, in fact, that they aren't. They're there when you need them. And in this case, because they weren't there, we were not ready. And I think this has been borne out in virtually every country. So there's actually a global health security index that will help countries to evaluate their preparedness. Some international analyses were done of this. Well over 100 countries were evaluated and nobody passed. This is my own version of what you need to be prepared for a pandemic. You got to have staff. They have to know how to talk to each other. You have to be able to detect what's going on. You need to know what essential services are so that you can maintain them. You need protective equipment and protective social measures. For example, how far apart should you really be staying, when and why? You need to know how to, you need to have the capacity to transport patients, to treat them, to house them, and the people who come with them. If, for example, they're coming in from a place that might be remote into, say, a city for hospital care. And you need R&D capacity in case what you're trying to handle is a novel infection. In this case, it was a novel virus. And we really needed the capacity to be able to figure out how to handle it. You need to be able to dispose with bodies. You need to be able to reintegrate patients You have to figure out how you're going to turn back on all of the economic activity within the society. You have to be able to monitor on a continuous basis what's going on. And you have to find some balance between protection from infection and disruption from controls. So in this particular event, we didn't have common response principles. We had a lot of inadequacies. We had a lot of shortages, and collectively we failed and we got overwhelmed. So I'm going to let you read the stuff on the left. Give you a few seconds because I want to read the one on the right. So on the right, it says, wanted. These are my two favorite nurses. Volunteers who don't believe in COVID-19. Activities include transfer of patients, transfer of the dead, general cleaning of the COVID ward, and personal care of COVID patients. P.S. It won't be a problem that you won't get personal protective equipment as you don't believe that it's necessary. It's been a terrible problem for us trying to handle this disease that a lot of people have said it's not real. So the public health response initially was based on our past experience. What we said was it's being spread by droplets. Then we added to that fomites, which are surfaces on which droplets might be present. You can see on the right what happens if you cough without a mask and what happens if you cough with a mask. And that's basically how we said this stuff was getting spread around. Finally, though, after about 6 months, we began to accept that this is actually being transmitted in the air. And there was a reason why we didn't want to do that, and that's because we used to deal with what were called miasmas, and they were blamed for infectious disease. When we discovered bacteria, we had a hard time convincing people that they needed to clean and dispose of their wastes to prevent infectious disease. And so we've been fighting that ever since. It is, in fact, now well established that people who've got SARS2 have a cloud of droplets around them. If they're moving, that cloud gets left behind. As it spread, public health officials began to convince politicians that they needed to act. One of the things that's starting to come out with criticisms now is that politicians acted too late. So, a lot of people saying anywhere from 1 to 3 months too late. A lot of different measures were used, such as, for example, public health messaging, but people even did things like putting out hand sanitizers. The public health messaging itself was very similar to what we had in 1918-19 and continuing into the 20s, and not quite waves, but definitely was present. Cover your cough, wash your hands, don't spit, wear a mask, be outside as much as you can. And we have very similar messaging going on right now. Unfortunately, it has proved insufficient. So additions to public health advice, once we got testing and we were able actually to determine who was infected with the virus, we could send people for testing and get a confirmation that, yeah, that guy's got it. We better be careful with him. Prior to that, it wasn't possible. So this would have been around March. In absence of a vaccine, we started to close all kinds of places. We're going through that right now in Ontario, perhaps not particularly effectively. There are lots of other places that are doing it better than we can. They just had a new case of community spread in New Zealand this week, one case, and they've decided to close down the country until probably the end of 2021. We've been cutting hospital services as well, and that in and of itself is problematic because it may result in deaths, which are in effect caused by the virus, even though the person may have some other health problem. So public health measures became stricter as infection worsened. We were asked to remain in our homes. We've got a stay-at-home order in Ontario at the moment. In Quebec, they've got a stay-at-home at night order. It's a curfew. We closed our parks. We closed our schools. Places that tried to open their schools too early got a wave of infection, as happened in Israel. Terrible problem there. We were asked to stay apart from each other. Probably 2 meters is insufficient. A lot of people did more cleaning, not necessarily always done in the best of ways. Like the guy on the right is probably just resuspending stuff that's on the floor. Restaurants were asked to limit their activities. People were asked to limit their contacts. Nobody had heard of social bubbles before this, I suspect. We were told that we would need to get tested. We needed to isolate if infected. We needed to quarantine if we'd been in contact with somebody who'd been infected. Here is an interesting case. I just can't imagine this happening in the Western world, but in Vietnam, they had 3 cases at a hospital. It resulted in over 50,000 people being quarantined. But what happened as a result is they prevented community transmission. So controls lessened infection, or in some cases, they were relaxed as a result of public pressure. And what happened as a result was, well, wave 1 was waning in early summer. People started to congregate as the restrictions were lifted, and infections started to rise. When schools reopened in the fall, wave 2 really hit us hard. And despite the fact that we had 1.5 million dead by September and the infection rates were rising, there was still growing opposition to head controls. So here we find ourselves now with over 2 million dead. Meanwhile, efforts against the spread of the virus were increasing, especially in terms of the medical effort. And we have now, in fact, produced vaccines, and we do now, in fact, know that certain medications work and others don't. We've been spreading the use of personal protective equipment and starting to expand its production. We are nowhere near where we need to be yet. We've, I think, just started the first production of N95 masks in British Columbia within the last week or so. And we've expanded use to things like construction. The detection of infection has improved greatly. We've got a lot of different methods for doing it now. We do run into the problem of false negatives and false positives. False negatives are more common than the false positives. The false positives have more weight. Sorry, the positive results have more weight in that we know these tests are quite specific. So if you do get a positive result, you've got something that's important. If you get a negative result, it's not necessarily the case that you're out of the woods. You may need to be retested, and you certainly need to monitor yourself, if not have some other people monitoring you, like the doctor or others in the family. We do now have rapid RNA antigen tests. We have antibody tests, and we have recognized that asymptomatic carriers are present in high frequency. Just this week, there's a new, it's actually a PCR test, but it's a rapid test. Results come out in less than half an hour from Spartan Biotech, which is a Canadian company. So false negatives, bottom left on the chart, are quite problematic because they can result in undetected cases, which will allow the infection to spread, cause more illness, more death, loss of employees and family members, social disruption. False positives, on the other hand, are perhaps more of a problem. If somebody could admit that person. There's just a whole raft of stuff that happens if you get somebody who's a false positive and in fact should never have been recognized as having had the illness. Interpreting the test results is nowhere near as easy as you might think, in part because how you interpret the result depends on how much of the illness is circulating in the local community. So I would say we should be leaving interpretation of the test results to people who really know what they're doing. When I started looking into this, it just got mind-boggling and complicated. We are studying the roots of infection still. We do know where it's airborne. We're starting to use N95 masks, I think, to a greater degree, and we're now starting to see suggestions that they ought to be getting used by people in the public as well. We're also starting to see face shields, and if you got a lot of money, you could probably get yourself a little helmet like the guy on the top left, top right there. The current public health advice basically is everybody should be wearing non-medical masks, and we should be distancing. A lot of people resent this. Not much we can do about that. It's kind of like the guy in World War I trench. Gee, I'm tired of being down here in the mud and all cramped up. I think I'll stand up and stretch my legs. How long do you think he's going to last? As of December, we were seeing very little health advice about ventilation and filtration, but I think that's critical, and I think you're going to see that grow over the course of the next 6 to 12 months. We do have, however, lockdown fatigue, just as they had it in the H1N1 early last century. There's been a long-standing refusal to admit the need for air filtration. I think that will probably change. Excess deaths are now recognized as really a good thing to be monitoring, in addition to deaths and hospitalizations in cases. Okay, I've got a problem. I'm not sure why. What's going on? Okay. Just make sure I'm on the right slide. Yeah, okay. So in that H1N1 experience last century, excess deaths really happened in the young adults. So the blue line right here shows the typical annual mortality rate based on age, and the red line shows what happened during that pandemic in the United States. So huge number of young adults were excess deaths. Some people are currently saying that the public health measures we've been using are drastic, massive, unprecedented. This is Mr. Kata, by the way. I would say we've never had 7.8 billion people with the degree of mobility and trade that we've been enjoying. So those drastic measures have in fact proven themselves really important. And I think we have not been doing them sufficiently. So here's an example of excess deaths. Up here on the right, you can see the United States had a lot of excess deaths in the spring. This doesn't go through to the fall. Well, sorry, it does go through the fall, but not through into the winter. Norway, on the other hand, didn't have excess deaths. And interesting, New Zealand had lower death. And that's because as a result of clamping down on travel, they had far fewer deaths from car accidents. Sorry, I can't read the top of my screen. I hope everybody else isn't having that problem. I don't know how to get that thing off. Doesn't seem to be able to get rid of it. Anyway, so this is the medical response. Detection of infection really improved. We now have rapid tests. We're still having trouble because I know that in our local medical system, for example, we don't even have enough swabs for doing the testing we need to do. Coding death was problematic when this started because we didn't have an ICD-10 code. That's the International Classification for Diseases code. We do now have such a code. A lot of people have questioned whether death from COVID-19 while ill with another disease is different from death with COVID-19 as a result of some other disease. I think that is a distinction that is moot. An excess death is an excess death. And we are so undercounting the COVID deaths that we can't even account for all the excess deaths that have been happening, as an example there at the bottom for the USA. So the battle against this virus has become a marathon. The virulence hasn't changed much, but we do have a lot of different strains. The chart on the right shows that we've been dealing with at least 7 different strains until quite recently. We know there have been over 12,000 mutations in this virus. There have been 3 new strains that have been recognized just within the last month or so. There's a UK variant, there's a South African variant, and this week it turns out there's a US variant that's come from California. There are 7 strains shown on the right in all those different colors. We do know now one of the real problems with the virus is it causes low blood oxygen, all kinds of problems associated with that, and not just in the lungs, but many other organs as well. And in fact, we've recognized COVID-19 as a vascular disease. The immune system gets disrupted by this virus, and in particular, the virus interferes with the production of interferon. The chart on the right shows that the people who are most severely ill have the lowest production of interferon in their blood. And it does appear that people who've got mutations that limit their ability to produce interferons on their own are the ones that get the sickest. We do know that ethnic groups are being affected differentially. We're not sure entirely why that is the case. We do know that hyperthermia, that is, as I mentioned early on, if you can simulate a low-grade fever, can stimulate the production of interferon in your body, so it may be a good idea to do that. If you need more information on that and you want to contact me at a later date, or you want to read those particular citations, you're welcome to do so. So the care protocols are currently being formalized. I want to see if I can move this script to the bottom. Yeah, okay. So this is about treatment of patients. The care protocols are being formalized. In fact, this week, the WHO came out with a new care protocol. Our medications are being used to ensure that patients are properly nourished, that they have as little fever and pain as possible, unless in fact that low-grade fever is helpful in their immune response, in which case you do not want to reduce the fever. We want to control blood coagulation. We want to control inflammation. We want to control secondary infection. And there are various things that we can do to administer drugs to people to help them get through this, like vitamin C, thiamine, low-weight heparin, etc. The next page. Okay, so here, for example, is one of the general approaches to treatment. I've added the red line in the middle. There's a kind of phase 1 and phase 2 to the illness. When the virus is replicating, you get fever, malaise, cough, headache, diarrhea, etc. Later on is when you get the hypoxia and the organ damage. And your doctors are going to treat you quite differently in the 2 different phases of the illness. This is my current rough rule. If you have 1,000 people, sorry, I can't get rid of this. If you have 1,000 people, you're probably going to get around 100 infections that'll cause 20 hospitalizations. 5 people will end up in the ICU, intensive care unit, and somewhere between 1 and 3 of those people will die. The death rate has actually dropped from close to 4 to closer to 3. That's probably because we recognize better what to do and what not to do when treating people in hospital. It may also have something to do with the so-called harvesting of susceptibles. So the people who are left are a little bit better able to cope with the virus. We've had terrible trouble, though, with the number of people who died in Germany and Italy, for example. They're 2 of the countries that have the highest infection rates in Italy, sorry, in the EU at the moment. They're storing bodies in shipping containers because they can't bury them fast enough. The United States has lost an awful lot of its elders. This is pretty significant because they make up nearly a quarter of their population. Dealing with elders and others requiring long-term care remains problematic. It was problematic before the pandemic started, and it certainly is the case now. there's a debate going on just today about whether we ought to be changing the way that we structure long-term care in the province of Ontario, and some people are calling for us to get rid of long-term care homes for profit, because the number of people who have died in those homes has been far higher than the number of people who died in not-for-profit homes. Can I move that? No. Okay. I hope people haven't had that little band at the bottom of the screen preventing them from reading enough of the screen. Okay, so what we don't know remains substantial.
Just so you know, David, your slides are showing up absolutely fine. So
Okay.
you're having a problem, but we're not.
Great, thank you. It was difficult for me because I can't read what's supposed to be on the screen. Okay, so what we don't know remains substantial. We don't know how long immunity is going to last. It looks like it's probably going to be 6 to 8 months. Don't know if it's more. We don't know whether exposure to other cold viruses might lessen the degree to which we get sick. We do have now mixed evidence. We were hoping that convalescent plasma would work, and it's really not working. We were hoping that antivirals would work, and they're really not working. And there's a real controversy going on over hydroxychloroquine. I know that it is being administered in some places, not much in the Western world. But it turns out that a couple of the papers that purported to say that hydroxychloroquine was a good thing to give people were based on a database that seems really, for all intents and purposes, to have been invented by a firm called Surgisphere. So the papers were retracted from journals like The Lancet, but unfortunately, they're still being cited. So it turns out that prone positioning, which is known from other diseases to help with people who are really sick, has some utility in fighting COVID-19. One of the things with which we're currently struggling is how to deal with patient surges. We're starting to use the so-called hospital at home, where you keep people who are not really, really ill out of the hospital completely. We're starting to repurpose wards. So for example, neonatal wards are being closed and they're being turned into COVID wards. We're starting to build new hospitals. Some of these are bricks and mortar hospitals. Some of them are rather temporary. Some of them just take over something like an arena and turn it into a hospital. And we're starting to build isolation centers. As it turns out, we do have about a dozen of these across Canada. And we have just recently started vaccination. There are already 4 or 5 different vaccines that have been approved in different parts of the world. There's a lot of controversy going on about that right now because of slow rollout. There are about 300 vaccine, actually over 300 vaccine candidates, by the way. And they fall into 5 major categories that you see on the top line there. You can come back and look at this chart on your own at a later date if you wish. Suffice to say, some of these are new, especially, for example, the one on the left, the mRNA vaccine. We've never had one that's been used with the public before. We don't know how SARS2 is going to evolve to evade antibodies. Initial evidence from one of the vaccine makers is that their vaccine remains effective against one of the newly discovered variants. We can't yet calculate just how many people are either going to need to be exposed and recovered or to have been vaccinated before we have sufficient so-called herd immunity to protect people who are unexposed. It may never happen. So the supplements, I'm already taking these supplements. Vitamin C, because it's water soluble and can be eliminated from the body easily. Virtually, you can take as much as you want. Linus Pauling used to take the stuff by the gram every day, actually by the hundreds of grams per day. You can probably take up to around 4,000 international units of vitamin D. And I do know that in many hospitals, if somebody comes in with COVID-19 at early stages of the infection, they will give them massive doses for the first week of vitamin D on the order of maybe 40, 50,000 new national units per day. And then they'll cut back. And zinc as well seems to have some effect. And by supplementing all of these ahead of getting infected, you may in fact be able to limit the degree to which your body gets attacked. So early on, there were a lot of differences. You can see all the different provinces of Canada and quite different rates of infection. But in wave 2, the rates of infection have really been quite similar. The only group that has not responded that way is the Atlantic Canada bubble, which is in danger of getting popped at the moment. We've learned a lot of lessons, but I think we're still going to struggle next time. What kind of an infection curve you get is going to depend on the comprehensiveness of the measures you put in place, but also the compliance that happens with those measures. And if you don't put in place sufficient enforcement measures as part of your public health measures, then I think you really run the risk of having low compliance and terrible problems with big waves of infection. We unfortunately had let suboptimal health conditions become far too common in our population. If they hadn't been so common, we probably would have had a lot less illness and death. An awful lot of things remain unknown. So I've got some notes on the side from very recent editions. The economic effects, well, I suppose we should start with closures. Who knew what a non-essential place was before we started this? We still don't really have good definitions of what essential services are. You'll note that liquor stores is on there. I would have guessed that really wasn't essential, but it's been classed as essential in most places. We do know what non-essential hospital services are, and we're cutting back on a lot of diagnostic testing and elective surgeries. I think there are probably people listening to me now who have been in that situation. I certainly have friends and acquaintances and family members who have been in that. We've closed down a lot of different kinds of economic engines. And as a result of such closures, we had a massive drop in GDP. You can see it here in the spring in Canada, and this happened in virtually every country. And we had a massive drop, you can see on the right, in our stock exchange. As a result of that, that happened worldwide as well. It really turned into a she session because the majority of the job losses, and you can see that the job losses were far more intense in this experience than they had been in the 3 previous recessions, which are shown here by the gray bars. Most of the job losses have been among women. Recent job report from the United States, 160,000 or so jobs were lost among women. And at the same time, there was an increase of about 60,000 jobs among men. This is in December. So really, she says, small businesses have had their income drastically cut. Renters have been in real danger of getting evicted. Landlords have lost a lot of income. Hospitals have been swamped. We've lost a lot of citizens. A lot of families have been left grieving. And a lot of people have had their mental health suffer. You can see what hospitalization looks like in the United States on the right. That's a common experience in most places. So I would say that free markets are not meant for pandemics. Without government aid, people often had to use food banks. 1 in 3 people in the United States is in food insecurity. At the moment, it's only 1 in 7 in Canada, and that's in large measure because of government support measures across the country. Many businesses either got bailouts or failed. It's particularly bad with small businesses that typically don't have a lot of resources uh, waiting on the sidelines. We have, as a result, though, had huge government deficits develop because there's less economic activity, which means less tax revenue, and there's been more spending at the same time. In particular, nations, the poor were hit the hardest, but it's the richer nations who fared worse than the poorer nations. And my belief is that that has to do with the air mobility of people in the rich nations. The charts on the right show a positive correlation between Gini coefficient, which in and of itself shows the higher the Gini coefficient, the more income inequality there is in a country. So what's happening here on this chart, okay, so the more income inequality there is, the more infection you have. That's why there's a positive correlation there. And you can see that here on the lower left, in the cases per million, North America and Europe have the highest cases per million, and Asia, Africa, Oceania have far lower cases. Economic activity recovered slowly. We had these massive drops in the spring. About a quarter of the Canadian economy was heavily affected in March and April, and we're still actually really below levels where we were in February. Consumers have adjusted by buying some things online and buying essentials in stores. Sometimes they are stocking up and hoarding on them, so it's hard to find things like bathroom tissue for some strange reason. Minorities have been greatly affected by this. What you can see here in the white is these are communities that have a low proportion of visible minorities. In the blue on the right, this is more than 25% of the people in that area are visible minorities, and so approximately 3 times the death rate. We do know that hard border closures have worked. I mentioned New Zealand earlier, and they're now probably going to be closed for the rest of the year. The Atlantic bubble did protect the 4 provinces. The North has just in the last week or 2 had a problem because they've got an outbreak going on. They did not prevent somebody from flying in from the south who was infected. We found that in places where they had a hard lockdown, there was actually, you can see here in the middle, less of an economic effect than in places that didn't do it. And that the people who were in those hard lockdown areas were actually more appreciative of their governments than in areas where they didn't have that lockdown. So we also found that near zero COVID policy jurisdictions fared better in wave 2. And you can see that in the chart, because even though we're really not getting towards near zero yet, Sweden is the blue line on the top there, had a far worse experience than Germany and Canada, which have had public health measure suites that have been far closer to near zero policy. Inequalities mattered before, they've been heightened during the pandemic. You can see the top bar, this is people who are melanin deficient like myself, and people who've got a lot more melanin in their skin have been more greatly affected. I think I said earlier, we don't really know whether that's because of the skin color or some other factors. And eventually we may find that it is in fact socioeconomic factors. A lot of these people working in particular types of jobs and living in particular types of housing situations that made their experiences worse. So all this lower economic activity and travel has greatly reduced air pollution. Interesting shot, lower right, this is in Delhi. People have seen their city and they've seen the countryside in many places that we're living, for example, close to mountains, not that Delhi is, but in places that were close to mountains, there were people who'd never seen the mountains, and now they can. Also experience from Delhi here on the left it actually shows that people who had solar panels got more electric production out of those panels when the particulate pollution went down. So this is what happened to CO2 emissions, down about 7%, less so with non-combustion related greenhouse gases. However, it has really not made a difference to the amount of carbon dioxide that's in the atmosphere, which is this lower right chart. You really can't see any difference between what's happened over the last year or so and what was happening in the last few years. And you can see in the lower left chart that for all intents and purposes, our activity is back to where it was. So a very short hiatus in emissions. There's going to be approximately a year, and if it goes on for another 2 or 3 years, there'll be a short annual fatality rate increase. There will probably be a drop in the annual birth rate, but it's very likely that it's going to recover pretty quickly because that's been the recent experience with some other pandemics. Food insecurity worsened during the pandemic, but global supplies were not compromised, at least up to this point. We've got about 137 million more people facing insecurity. That's up about 80%, but prices are still pretty stable and there are still food supplies. The grain market is still well supplied. What I would offer though is that we've got no new major famines yet. Big proviso. We don't know what's going to happen next year. You've had other markets for particular goods that have been compromised, and I think this is very likely related to how much labor is involved in any particular product. The more labor that's involved, the more likely that a market is going to get disrupted. That's just because people are getting sick or they have to be kept further apart. So government spending has surged while private spending has shrunk. Just a second, I'm going to check a note here. Okay. There are a whole bunch of different ways that governments have tried to help their populations and the businesses on whom those populations rely. Reopening has to be done very carefully. I think our initial experiences with reopening were really eye-opening because we went too fast, and as a result, we went right back into a second wave. So SARS2 is our most expensive pandemic ever. You can see some comparisons at the bottom to our recent pandemic experiences. Basically an order of magnitude more costs associated with SARS2, and it's by no means over yet. And how does it compare to H1N1? Well, $9 trillion in cost and 0.025% of the population killed. And adjusting for inflation and spending power and all that stuff, 2019 dollars, the H1N1 flu in 1918 to 20 was approximately $1 trillion. It was 6% of GDP. It was about 3 years long. We lost about 2.25% of the entire population of the world. For comparison, there was a 5-year war that had just ended, and the combat deaths in that war were 0.5% of the population, so approximately a fourth or a fifth. And we're nowhere near that yet. We certainly hope we don't get there with SARS-2, but it's got the potential to get there, especially if it turns out that some of the variants that are emerging are not only more transmissible, which we know with the UK variant, for example, but perhaps more resistant to the vaccines we've developing. Initial indications, I said earlier, are that the vaccines will still work, or that those new variants become more deadly. So here's a hypothetical sort of economic analysis of what would happen if you had 1 million deaths in the US. And certainly by mid-February, if not before, the United States is going to hit 500,000 deaths. Given that in general, what goes up must come down, the number of deaths that occur before the peak are going to be mirrored after the peak, I would venture. So the United States is very likely to end up with at least 1 million deaths. And the cost of averting those deaths, if you were doing an economic analysis, would be approximately $10 trillion. So here are some of the societal effects that I noted. These are major changes. A lot of us working from home. We now know what an essential worker is. We're having a lot of trouble educating our kids. We are having a lot of trouble getting enough money without government help. Healthcare has become problematic. A lot of people don't even want to go to hospital because they don't want to get nosocomial infections. Those are hospital-acquired infections. And we certainly have noticed that going to a waiting room for any healthcare provider is kind of a time waster. Certainly, I know that I have had to see doctors 3 or 4 times, and it's been great sitting at home with a cup of coffee waiting for them to come online. The long haul victims, this is probably in the range of about 10% of the people who get infected are going to become long haul victims, and they may be a burden for years. And we don't yet know the extent to which SARS2 may integrate into our genes. We do know that integrating into the genes is something that viruses commonly do. And there's a really concerning report that I read this morning that shows that SARS2 remains present in the brain and may be resulting in relapses among some people. There's been some real abuse and much imagined abuse. Some countries have imposed or deepened their authoritarianism. Other countries have had some of their population feel that their rights have been breached unreasonably. This has certainly happened in Canada to some extent, in a much greater way in the UK and in the United States. So this is probably a guy of whom you had never heard before, and you may have heard of him by now. He's a prominent epidemiologist at Harvard, Mark Lipsitch. And he said, basically, this is dominating all aspects of life. The virus doesn't care who you are. Wishful thinking isn't going to work. Masks will work. Viruses spreading is what's bad for an economy, not closing down the economy to prevent such spread. SARS2 has changed economies, education systems, sports, entertainment, the arts, virtually everything else. And from what I've been reading, we can, and from the experience with the H1N1 in 1918 to 20, we can expect these changes to continue at least for 5, if not 10, maybe even closer to 20 years. In December, some people came out with a proposal for what they called the Canadian Shield that they think is going to cut our deaths from this point onwards in half, but it requires a really hard lockdown and remains to be seen whether we will find that palatable. What might we conclude thus far? Healthcare systems remain at risk from underfunding and privatization. This really matters because the systems that function well are going to save lives and reduce suffering, and those that don't are going to do the opposite. Our economic systems are at risk from myopia and short-term focus. This really matters because systems that function well will be sustainable, or at least have the potential to be sustainable. The pandemic will haunt us for decades, and we had better become better at evaluating, preparing for this kind of event and responding to this kind of threat, or I think you can see where we're headed. And that's it. I thank you for your attention. I hope you enjoyed it.
Thank you, Dave. I hope everybody can hear me and see me. Yes. Anyway, I just wanted to say thank you very much for that. You you covered an awful lot of material in the hour that you spoke. So I'll give you a chance to take a drink of water and pause for a minute. The first person to have a question or a comment is Barry Bruce. And so Barry, and on tap is Anitra. So I would ask Barry if he could make his comment, please. Thank you.
Oh, it was a bit of a throwaway comment, but
Yeah.
just a comment about megadoses of ascorbic acid. Ascorbic acid is broken down into oxalic acid, which can combine with calcium to make kidney stones. So I'm a family doctor. I've been advising people not to take megadoses of ascorbic acid. That's just a comment. And
Being somebody who's had kidney stones before, I will definitely be paying attention to that, but I take fairly low doses.
Thank you, Barry. Anitra.
I hope you can hear me.
Yes.
Good. I think one of the basic questions is why most governments in the world and medical establishments were so poorly prepared doing anticipatory problem solving for a large microbial pandemic, when people like the Ehrlichs and others have been talking about this for many decades, when our cities are so much more crowded and when the population has grown to so many billions of people, plus the air is degrading and people are living much closer together, especially in Asia and massive cities throughout the world. It seems to me that this is just an obvious kind of result of everything that we have been doing in our living and becoming urbanized, and the fact that the governments were so poorly prepared, and in fact the hospitals so poorly prepared, is the surprising part, not the pandemic.
Oh, I agree 100%. I think in part one, I said that we came together in these enormous cities, we grew this huge population, and we failed to adapt our systems to it.
Is that okay?
Yes. No, that's the answer.
Okay. All right. Thanks, Anitra. Dave. Jeff Passmore, you're up. Thank you.
Hi, Dave. You had a couple of slides on antibodies, and I just want to make sure I understand. Are you saying that someone who's had COVID-19, the antibodies will remain in their blood for 8 months, and then after that, there's no point in having an antibody test?
Well, I wouldn't go so far as to say there's no point in having an antibody test, because the reading that I was doing was related to whether physicians felt that there was going to be sufficient memory to prevent a relapse or reinfection. And we only know because we only have experience from approximately, I guess, 8 to 10 months at the moment, but early on we were really not collecting samples to know what people's health status was really like. We were too busy trying to save their lives. So, 8 months, they're pretty confident, at least it's getting into the scientific literature, that there's evidence that there is some residual antibody load in the blood. Now, whether that is going to allow you to mount a sufficient response to avoid severe illness or death remains to be seen. We will probably see it in wave 3.
Okay, thanks. It's just as a matter of interest, because I was very ill in December of 19 after having had a meeting with a number of folks from Finland, and temperature of 103, and was sick for 2 months, coughing and so on. And then so now you can go and get an antibody test if you pay $70. It doesn't mean you won't get it again, but my wife was interested in knowing whether or not I had it. Now, no one around me caught it, so that would lead one to believe that my sister was visiting from Scotland, and my wife, of course, was living in the same bedroom. So I doubt I had it, but it would be interesting to get the test just for an interest's sake, perhaps.
Well, you might want to consult your physician about it. One observation I might make is your physician might tell you that victims of COVID-19 don't tend to get temperatures as high as 103 degrees, but you might have had some kind of other lung infection.
Right. Okay, thanks.
Okay, up is Art Hunter.
Yeah, Dave, thanks for that. That was a very comprehensive presentation. I want to just go back to risk reduction and avoidance. I want to thank you for telling me that I should use my sauna more, get my body temperature elevated, and followed by a cold shower. That sounds wonderful. I'll do much more of that now. Of course, you know that I'm a big fan of UVC as a means to kill the particle good and early before it gets breathed in through your everyday operations within your house. Have you had anything recent on UVC that says it's being highly recommended? I mean, I can recommend it, but I'd be really happy to see some, people with much higher medical credibility than myself to say that.
Well, you asked whether I'd seen anything recent. I have not seen anything recent. The last reading I did on that was from about September, October. And there were some machines coming onto the market to disinfect the air in your house using ultraviolet light. I'm not certain whether it was UVC.
Okay, thank you.
I can look into that if you want.
Great, thank you. John Pierce, you're up.
Yes, I'm wondering if everybody has realized that this pandemic is actually the moral equivalent of war. I think if you recognize that, you will have a better appreciation of the kind of economic recovery measures that are needed to deal with it. And the US has been the poorest at it, perhaps US and Brazil. We're sort of halfway in between the US and New Zealand and Iceland. Helps that they're islands too. And that helps within Canada as well.
Yeah, certainly. From my perspective, I think I started saying that we needed to respond to this as if it were in fact a war back in March.
Well, that's, wow. Well, I think this government did a reasonable job with the guaranteed annual income. That's what you have to do, because you can't have a healthy economy with an unhealthy workforce. And this seemingly simple point is too complex for the nitwits south of the border.
Well, the other thing that, to go back to that little story I told about a guy who's, sick and tired of being down in the trench in the mud with his knees up around his ears. One thing that we probably haven't sufficiently done is public health messaging that's designed to get people to accept what is happening and figure out how to deal with it. If you're in a trench and the reason you're in the trench is because the machine gun bullets are flying like crazy and there's shrapnel flying everywhere through the air, the last thing you do is stand up.
Yeah.
All right, thank you. Bob Walker, you're up.
Thanks, Jane. Dave, wonderful presentation. Wow, that's a great piece of work. Appreciate enormously you putting that together. I just highlight that one of the dimensions of preparation is the ability of a nation to surge. And one of the lessons we've learned is that Canada's become highly dependent on offshore supply chains. And for pandemics, you got to be able to surge around testing, around medications, and around PPE. And in Canada's case, in every case, we were overly dependent on offshore supply chains. And this is one of the dimensions actually in wartime, is your ability to scale up production. Oftentimes in a war setting, you have allies and you share the burden across allies. In this case, we tend to be a case where we're all having to do it ourselves. And so this takes some rethinking your ability to surge. And I know there's discussions going on in government of how you position through the government's the means to support economies, the capacity to not to be overly dependent on free markets, but to be able to onshore critical supply chains. And perhaps more a comment than a question, but enjoyed your presentation. Thanks.
Well, just to carry that a little bit further, I agree with you completely. And I was working in Health Canada circa 2010. One of the research projects, I used to run a small economics research unit. And one of the projects that we undertook was looking at surge capacity across the country to deal with something like H1N1, which actually did hit in 2009, if you remember. And it would have been relevant to this. What we found at the time was there was no surge capacity at all. And to take up your issue about offshore supplies, you know, I'm a child of the 60s and 70s, and there was a time when, in large measure, Canada was at least to a much greater extent than it is now, a self-contained unit. We produced our own stuff. We made our own shoes. We made our own clothing. And these days, we don't. And that we have come to this makes no sense to me. But, you know, I think we can thank Mr. Mulrooney for it.
Thank you. Okay, next person is Barry Bruce again. Thank you, Barry.
Okay. Well, you may have just answered it, but I'm wondering why we have no homegrown Canadian vaccine. I think we had something to do with producing the Ebola vaccine, but we seem to be unable to do anything domestically in this case. Why is that?
Jean can correct me on the name of the firm. I think the firm is Providence. We actually do have a vaccine maker who has developed an mRNA vaccine, but it's, I think, now only reached phase 2 trials, and it's about to move into phase 3. And they actually went to the government many months ago and said they'd like to get some funding so that they could move to phase 3 trials, and they didn't get it. It looks like they're about to get some now. With any luck, we'll be able to produce a vaccine within maybe a year and get it onto the market.
Sounds a little late.
Yeah, a bit late, but it is an mRNA vaccine manufacturing system. So if they do get it in place and can start manufacturing, it'll be the first one in Canada that is an mRNA vaccine manufacturer here.
Yeah, they had been producing it in Toronto, but when they do their scale up to try to get to a phase 3 trial, you need enough doses. They're moving their production facility to Calgary. Was I right on the name of the firm?
Yeah, there's a second part to it, and it's on another piece of paper. I haven't gone to get it, but I can send that around later. Okay, thank you. Ted, you've got a question or a comment.
Yeah, I guess so. Okay. Have we learned anything that would allow us to understand what kind of government, what kind of approach will allow the world to work together to actually address a COVID or a climate change or any of the other things that transcend the ability of single governments to take it on? I mean, we have a pretty good model there in New Zealand of taking on isolating and putting itself into a separate category and trying to operate outside of the global issue. But what about the whole world?
Well, in some measure, I think we knew how to do this, but not enough of us knew how to do this, and not enough of us accepted how to do this, which is why, while we did have the WHO in the first, say, 3-4 months of the pandemic, the WHO wasn't doing what we needed it to do. And countries were not cooperating with the WHO to the extent that they needed to. And then you have the United States turn around and say, well, we're not going to cooperate at all. In fact, we're going to withdraw.
So what will it take to get people to actually work together for the common good? Don't answer that too fast. It's taken people decades to even define the question.
How many PhD theses written on that?
Yeah. Anyway, thank you, Ted. Catherine, you're up.
Okay, I just wanted to add a wee bit. It was just following up on Jeff's question earlier about, he was asking about antibody tests, getting an antibody test, trying to figure out whether maybe he had it earlier. And all I wanted to say was that it's a very, and I'm not an immunologist or anything like that, but it's a very complicated thing with antibodies, because it is normal for the amount of antibody in your blood to wane after so many months of after having an infection. You may have a little bit of it, but this seems to vary from bug to bug. But the thing that's important to note is that there's actually a second kind of cell called a memory T cell in your part of your immune system, which may not be visible with these simple antibody tests, but it still may be there, and it still may be able to spring into action if it is exposed to the virus. So my point is that the antibody tests, it's not clear from what I understand, and Dave, you can correct me if this doesn't sound like what you've heard, but level of antibody in your blood doesn't necessarily mean, let's say it's low, that you're now completely unprotected, is the point, because you're basically storing memory in these cells rather than just having circulating antibodies floating around. So that was what I just wanted to share.
Yeah, I think you're correct. We know that the immune response is essentially two-part response, and the antibody thing, this is about really essentially phase 1 of your immune response. If you were to get it and you don't have enough of that circulating around, then you might get more ill. So your illness might advance to a greater extent than if you already have that. If you've got the memory T cells, they take anywhere from 1 to 3 or so weeks to get reactivated and mount a sufficient response to be able to fight off the virus. So then the question is, well, how much of the virus do you have in your body by the time that response gets there? And there's a complicating factor because the virus seems to disrupt the immune system and actually cause inflammation. And so if the whole thing doesn't work properly, then you're going to get advanced illness.
Thank you. Susha, you have a comment question.
Yeah. Well, thank you very much, Dave. This is such a comprehensive presentation. So question goes in the mind that now we learn how to have a lot of things working on the internet, and the travel is done with, and can we live sustainably now? Can we ban forest cutting and construction? Can the government survive without big donation from builders to actually ban all the construction or almost all of it?
Well, in some measure, I guess that's a rhetorical question. I would say that the opportunity presents itself that we do exactly that. And the question is, to what extent are we going to try to return to so-called normal? Or are we going to recognize that there were some major problems with what we had considered normal that we have the opportunity to correct?
Is that sufficient, Susha?
I guess so.
Okay, all right.
Yeah,
I mean,
okay.
if you ask, can we do it? Yes, we can do it. Will we do it? That's a whole other question.
Okay,
Yeah, yeah.
thank you. Jeff, you had another comment question to ask.
Well, nothing really. Actually, I'm interested in Catherine's comment about antibodies because you know, it's all very complicated. But all I wanted to know was whether it was worth spending the $70. And my doctor's already told me that even if I have the antibodies, it doesn't mean I'm protected. So you know, but no, I don't. I had two other comments in there, Dave. You can comment on them or not as you see fit. But one was I thought that I had read that there would be a COVID boom in birth rates, similar to the baby boom, because everybody's staying home with COVID now. And you had mentioned the birth rate might go down. I'd heard the opposite. And then I'm not convinced that the cases per million that we're getting from many developing countries is reliable, because they don't have the capacity to collect that data necessarily as well as, you know, Europe and North America, for example. But comment if you feel like you want to, but not necessarily.
Sure. So on the boom, I'm pretty sure that we already are seeing a drop in birth rates. So couples have been too scared, especially women have been too scared to go into hospital at this time. And they're just trying to avoid expanding their family. However, once the pandemic is gone, we're very likely to see a recovery in birth rates. And in fact, the birth rates may go higher than they had been previously. And as far as the cases go, I think maybe a fair comment would be, don't have too much confidence in just how accurate the case counts are, even in the richest nations.
All right, thank you. Steve Harris, you had a comment question.
Yes, you know, I believe it as the sole representative of the nitwits to the South. I just wanted to say hello to all my Canadian friends, and I added one comment directly to Gene, and that is, thank God, whether or not you believe in one, that Trump is no longer our president. You know, we still have a number of his ilk that we're having to deal with, and we'll have to deal with in the long term. But at least key positions in the government shouldn't be held by his appointees much longer if they are still there. Secondly, David, I had a question for you. The end of part one, you tossed out an idea concerning how the pandemic may be treated in the future. Do you have any updates or modifications to that that teaser that you tossed out?
I'd have to say I've been concentrating on part two so much that I don't immediately bring to mind the thing to which you are referring. If you could refresh my memory.
Oh, I think you were discussing a long-term living with COVID in the environment, and how it may be treated as a more a chronic type of condition in our environment, and that we end up you know, having some type of maintenance program as opposed to a curative program for it. You know, something similar to malaria, for instance.
Yeah. Okay. So if anything, I would say I am more convinced now than I was then that this virus is going to be with us long term. SARS-1, you may remember, essentially disappeared. but this one isn't going to go away. Among other things, it parks itself in our brains, and it's probably going to park itself in our DNA. The way it's looking at the moment, we are not going to mount public health responses sufficient to quash the virus entirely, and it's very likely to become endemic. So I would foresee that we'll have a lot of business for vaccine makers and medicine makers for quite a while. Oh, you know, as a matter of fact, I'm not even sure that I mentioned this. Just this week, we have a new trial that succeeded in showing that colchicine is very useful in reducing the severity of illness and the number of deaths. So we could see colchicine soon get added to our treatment protocols.
Okay, thank you.
Thanks, Dave. And I'm glad we've kept a few comments about political statements to a minimum if we can. Angie, you have a question.
Yes, I have a question. And it's, does anybody know anything about how effective the vaccines are on people who have challenged immune systems, such as transplant patients, people with underlying health conditions? For instance, transplant patients, transplant recipients have an 80% chance of dying, as I understand it, should they get COVID. One other quick comment I'd like to make is, please be careful. Too much vitamin D can cause nausea, vomiting, and lead to kidney problems. And the other very quick comment is, over here in the UK, I have noticed that whilst retailers and high street retailers are disappearing fast, which employ a lot of women, so I think Dave's comment is very relevant, the van drivers for all the new deliveries and the home shopping tends to be male. Thank you.
Okay, so in reverse order, of course, the Queen during World War II proved that the people driving vehicles did not need to be men. And so that's a question of your choice as to whom you hire as a driver. In my personal experience, I think women are usually the ones who are less of a danger to me as a driver than the men. In any case, back to vitamin D, it's interesting that in many hospitals, one of the first things they do with people who come in with COVID-19 is they give massive doses of vitamin D. So the extent to which maybe side effects like nausea and vomiting can be managed and make it worthwhile to give that vitamin D, might be something worth investigating. But it's perhaps better left to physicians who are going to be treating such patients. And then as far as immune compromised people and these vaccines, it's not clear to me. I haven't seen much in the literature. I must admit I didn't explore, looking specifically for that. I'll see if I can find something on it. I would offer this one thing. I think that our evaluation of who ought to be our prime candidates to get vaccines has been perhaps, shall I call it, lacking. It seems to me that we ought first to identify people who have the potential to be super spreaders and make sure that they are the ones who get vaccinated first. And if, for example, it turns out that, I don't know, the person at the grocery store who is seeing maybe hundreds of people in a day is in fact one of those potential super spreaders. I don't care whether the person is 18 or 45 or 65, that person should get vaccinated. If a person is, as for example, my mother-in-law was late in her life, largely sitting in her room and not interacting with anybody except the nurse who comes in to look into whether she needs anything every hour or two. Does she need to be vaccinated? Probably not. If you were to vaccinate all of the care workers who go in and out of a long-term care home, that probably is going to prevent the people living in the home from getting infected in the first place. So those are the kinds of people where your vaccines ought to go first. And if in fact it is the case that older people can't mount an immune response to the same extent that younger people can, why are we giving older people vaccines? Doesn't make any sense. Just doesn't make any sense.
Okay, thank you, Dave. Angie, I think our last question is coming from Zach. If you can go ahead.
Well, not so much as its questions. Yeah, I'm really interested in your last comment about older people, because I am one, and we need to know that very question. I've been thinking it. I don't dare ask it around the house, but I have been thinking it. And absolutely right about us identifying super spreaders. Absolutely, that was visible in SARS. It's visible now. It's so obvious that Canada, and for that matter, everybody, saw the lessons in SARS. We saw we had a perfect photograph of a perfect early century epidemic, and we paid zero attention to its lessons. Forgot them all. But I want to say also that was a wonderful talk. I do want to say one thing. That's the real reason I had a comment. Let's not forget, this is SARS-2. Remember Anthony Fauci, even before he was liberated, somebody asked him, this is before the pandemic too, what epidemics do you worry about the most? Thinking he would say Ebola or maybe H1N1. He said, no, SARS.
Yeah.
Yeah.
Yeah. Okay, thank you, Zach.
And,
With that, Dave, if I can say something.
Hang
Okay.
on. You know, the one that worries me is poverty.
Yeah. Okay. Thank you, Dave. Thank you, everyone, for staying with this and asking some pertinent questions. I think this was a really excellent presentation. And between the two of them, I think you've summed up the state of affairs with respect to COVID-19 and the pandemic that is being experienced by everyone. And I'd like to thank you very much for all you've done.
Here, here.